Welcome to the Exposing Mold podcast, where I, Keely Severson, Eric Johnson, and Alicia Swami are exposing mold. Today we have as our guest Dr. John James. Dr. John James is the author of a book called A Sea of Broken Hearts. And Dr. James, you also have the Patient Safety America.com website where you advocate for patient safety. Would you mind giving our listeners and us some background about how you got into this line of work?
Yeah, Keely, I'd be happy to do that, although it's not a happy story. In 2002, I lost my 19-year-old son to medical care in his college town that was not only technically incompetent, but was really unethical. And I'll explain that in a little bit. But he basically died while running. He had been treated for 5 days in a hospital in which they really didn't discover the cause of his first collapse, which wasn't fatal. And when I look back at his medical records, I realized that they had missed his potassium depletion. They had missed a key and easy diagnosis. And they knew they hadn't figured out anything, but rather than tell him not to go back to running, which he was a crazy runner, they never told him that. And so in the end, he died while running. I can say for any of your listeners online who've lost a child, it is not easy to recover from that. And it took me a while to get going. By 2007, though, I had written a book called A Sea of Broken Hearts, as you mentioned. And in it, I described what happened to my son. And my background is in pathology. That's where my PhD is. And so I can piece together the medical puzzle that was his care. And I also took his case to the Texas Medical Board, and that was a waste of time. Even though their websites, typically of medical boards, say they're there to protect patients from doctors that are not fully competent. That's simply not true. And that's another subject we could get into if you like later on. Then I started the website. I thought, what can I do that's different? And so I decided that, well, really, I have access to top quality medical journals through my library at NASA where I work. And I can take stories and studies and expert opinion from those journals and adapt it and summarize it for understanding by the general public, change some of the medical language and hit top level things about all the way from drugs to dangers to look for in healthcare. And so I've written a newsletter since 2008 and issue a monthly 4-page summary of what's going on in medicine that may be of interest to patients. And it's totally free. I don't need money. What I need is a change in the system. So PatientSafetyAmerica.com, my website, is a place where all those reside. I keep a kind of a repository, if you will, of all the newsletters I've written there. And I send one out each month to maybe 600 or 700 people. Well, I cannot hear you, Keely.
How can people sign up for your newsletter?
I think the best way would be to go to PatientSafetyAmerica.com. No spaces between the words, just Patient Safety America, one big old word.com. And I think in there you can see how to sign up for my newsletter, or send me an email if you want directly to john.t.james@earthlink.net. And it would be good to tell me a little bit about yourself, because I have different groups. If someone's a nurse or has worked in patient safety or maybe has been harmed by healthcare and wants their story told, tell me a little bit about yourself if you're interested in joining up.
Yeah, our podcast is full of people who are not getting the help that they need from the medical system, so it would probably be a good fit for your newsletter. And you described not being able to get help with your medical case when you approached the Texas Medical Board. Can you speak just a bit about that?
Yeah. So let's see. I think the best place to start is perhaps just a little bit before that. I did try to get legal uh, accountability for the mistakes my son's doctors made. His case was kind of complex because there were a number of cardiologists involved, and exactly who dropped the ball wasn't all that clear. In the end, no lawyer would take it. And it was also apparent that tort reform was coming in Texas. And so the ability to hold doctors accountable for mistakes was just about ready to disappear. So anyway, I decided to take it to the Texas Medical Board. And the few doctors I knew said, well, good luck with that. And they were right. I went in and I presented the case to the medical board, and they said, hey, your son's care met the standard of care. And then I was outraged. I thought, you got to be kidding. I was naive, honestly. So I took it again. I said, I want to come back. And they said, you're the first one that ever wanted to do that. I said, I want to come back anyway. So I did, and I laid it out again. And then they came back and said, actually, my son's care exceeded the standard of care. Of course, the details of that are inaccessible to me, how they actually came up with that. That's typical of medical boards. They don't share information. And even when I went back the second time, I had not fully realized the mistakes my son's cardiologist had made. But over the years and with some other people, and some people that read my book, A Sea of Broken Hearts, they said, yeah, we can see other things in here they missed. One old doctor I knew through my days at NASA, who had extensive experience with athletes and exercise stress tests, which my son had, said, let me tell you what they did wrong with his exercise stress test. And by then I simply said, I don't want to know any more mistakes. There's enough. Bill, I don't need to know what they did wrong. I've had it with what they did wrong. But at least there were 3 catastrophic errors that I identified. And I'm sad to say, I don't think this is atypical.
I would agree based on what we've seen. Now, you've said something interesting in your description that in Texas, the ability to hold doctors accountable was about to disappear, and you didn't know it at the time. I did see on your website some changes to the tort laws. So have the laws now changed in Texas to where it's even more difficulty to hold doctors accountable? And then as an aside or an add-on to that question, is this common in most states? I'm not familiar.
Okay, that's a good question, Keely. Yeah, it's tort reform, and the limit in this state is about $250,000 for damages. And in my son's case, a 19-year-old young man who was headed to becoming an Air Force officer, without tort reform, it could have been a huge settlement if his doctors had been held accountable. There's kind of a sliding scale, I'm sad to say, in many cases where somebody old, if they end up dying from bad medical care, the monetary end of the accountability is much lower because the expectation of their earnings, for example, would be much less if they were 70 or 75, say. I think medical boards, well, let's go back to the question of tort reform. So it's mixed here and there in some states. I have not compiled the data, but maybe a third of the states have something like tort reform, where there's a limited accountability for monetary compensation for the harm caused. But in some states, this is changing back. Some legislators are beginning to realize that this really limits accountability for medical errors, which are very serious, by the way. I'd like to get a chance to describe some of my work there down the road. What is not being well done by medical boards in many cases is accountability for sexual misconduct with patients. And there's been some, I think the Atlanta Journal-Constitution wrote a series of articles on how medical boards don't hold doctors fully accountable when they commit sexual improprieties, let's put it that way, against their patients. And in many cases, there's no requirement that a medical board that discovers sexual abuse of patients to report those abuses to law enforcement. That's a huge drop of the ball, in my opinion. If I were a woman, presumably, who had been sexually abused by a doctor, the first step would be to report it to law authorities. And then secondly, to the medical board. Just don't assume the medical board is going to go and report it to the legal authorities. It doesn't happen. So that's enough of a long-winded answer.
That's really unfortunate that it works that way. And I also heard you say that you wanted a chance to discuss some medical errors.
Yeah, so I was kind of cruising along about 2010, and I saw some new articles coming out that use something called the Global Trigger Tool. And it's a tool that medical doctors use to look for adverse events in medical records, okay? So then you find adverse events, and this thing's really good at it, much more than admission of adverse events. It finds them. Then the idea is, okay, was this preventable or not? I.e., was a mistake made that led to this adverse event? And there were 4 studies published that really looked in depth at this, but nobody was doing anything about it. The doctors weren't, nobody, the hospital people certainly weren't doing anything with it. They didn't want this known. So I decided to write a study up, and I ended up publishing it in the Journal of Patient Safety in 2013. And in that study, I estimated about 400,000 people die prematurely because of mistakes made in hospitals. That doesn't mean they died in the hospital. And that doesn't mean medical mistakes are the only thing that caused their death. It's just that their death was early. In my son's case, he died because he had ventricular fibrillation, because he was potassium depleted, because his doctors didn't recognize it and replace the potassium. So it's really a straightforward perspective on that. And there's a lot of other things. And in the year about 2000, about 100,000 people were dying early of heart failure because they weren't getting the drugs they needed when hospitalized to prolong their life in the face of heart failure after a heart attack. So this error of omissions is huge and is really not well acknowledged now. But that's why my estimate is so much higher, is I attempted to estimate that. And my estimate is higher than most of the others that have been done with similar data. But, by the way, no one's taken it down. A few have tried. One doctor wrote me and said, well, okay, so that's about 1% of the time hospitals do something that shortens somebody's life. Really, how good do you expect us to be? It's a good question. Medicine is complex. Can they do any better? I'd like to think they can, but it's humans. There's going to be mistakes. So anyway, later that year, 2013, I got invited to testify in front of a Senate subcommittee by Bernie Sanders on medical errors. And it was a heady experience for me, if you will, to be called up to testify in front of a Senate subcommittee. Once I got in there, I realized there wasn't going to be much of anybody in there. Bernie Sanders and Elizabeth Warren were there, but it seemed like no one else cared. And I was part of a lineup of physicians who testified and some change leaders. But my hopes that it would make a difference were pretty much dashed in terms of improving the safety of healthcare in the U.S.
It does pose the question, what will it take? Because I know everyone here on this panel right now has seen medical error and great harm from medical error. And I think that this is a concern that we all share. And I'd like to just turn this over to Alicia and Eric and give them a chance to ask any questions about what we've discussed in your area of specialty so far.
Thank you, Dr. James, for joining us today. And yeah, I mean, there's a ton of articles circulating that the third leading cause of death in the United States is from medical errors. And I don't know how true that is, but that is extremely alarming. And a subject like this needs more attention for sure. And I agree with you. And I wanted to just turn over the conversation to informed consent. How can patients protect themselves when they are seeking medical care?
That is an excellent question. Um, and the answer is not easy. The deck is stacked against patients. Typically, they seek serious medical care when they're vulnerable and sick. Uh, First piece of advice, have an assertive patient advocate with you, and one that's independent of the system if you can do it. Okay. Because you may not be able to look out for your own welfare, and you may not be able to make your decisions. So now let's talk a little bit about informed consent. I would say about 2016, I began to realize that changing the system was going to be very difficult. The system is backed by hundreds of millions of dollars of contributions to Congress and all over the place, and it just isn't likely to happen. So then, how can the patient protect themselves from a system that is designed to maximize profits in most cases, and at the same time squash patient needs? And the mechanism to do that is through informed consent and something called shared decision making, which was coming of age, if you will, in the early 2000s. There's a seminal article, I think, written by King and Moulton on the value of shared decision making. And what this is that the patient comes to the table when they're talking about their clinician, with their clinician, and has some idea of what they want in terms of preferences. And then the doctor shares the options with the patient. You can do this, you can have surgery, you can do physical therapy, you can try this, try that, maybe a drug will work, maybe we don't need to do surgery. What do you think here? And a well-prepared clinician will be able to say the risks. And here's the most important thing, perhaps, that people don't realize. Risk includes how bad an outcome is possible and how likely it is. For example, I might say, you could get killed crossing the street. Well, what's the first thing you want to know? What are the chances of that? If it's dark and I'm in black clothes and I can't do anything but crawl, maybe I got a good chance of getting clobbered. But if it's daylight and all this, you need to know the probability. And this is something I learned very firmly when I worked at NASA. It's always about how bad the outcome can be and what the likelihood is. And there we had a framework, if you will, where even if something really, really bad can happen, if the probability is so low, we just let it be. So anyway, that's when your doctor tells you, you know, you could die from this procedure. Well, doctor, what's the likelihood of that? Is it 1 in 10,000? Is it 1 in 10? You know, they need to know that, and they need to be able to tell you that. So anyway, in the wake of going after informed consent, I wrote a paper that was published in BMJ Open, British Medical Journal Open, in 2019, that asked the question, what does a reasonable person want to know? In a lot of states like mine, Texas, informed consent is predicated on what a reasonable patient wants to know. And about half the other states, it's what reasonable doctors want to tell them. That needs to disappear. Informed consent should be totally and completely about what patients want to know. Anyway, my putative reasonable patient was stuck in a hospital after coming in last night with a serious medical problem that had been stabilized. And so now the time is here for discussion of further possible invasive procedures. Maybe you need a cardiac bypass, maybe you don't. So I had 10 questions, and I ran them by some nursing students in Galveston. Now, that was great fun. They all have cell phones, and they took my survey, and in 5 minutes, the answers were available. And then I ran it through a bunch of really smart people I interact with in Vermont called the Health Professions Education Summer Symposium. These are doctors, nurses, and health administrators that educate people. They're smart and they know about the system. Then I did a national survey, a little over 1,000 people through SurveyMonkey. And what is clear is that the reasonable patient wants to know much more than is ever given during informed consent procedures. They want to know all their options. They want to know the history of devices. Is this thing reliable? They want to know about risks of drugs. Is it off-label? Do you know what off-label drug is? Do you know what a box warning drug is? Those are especially dangerous. They're still approved, but they're especially dangerous. Do you want to know who's going to do your invasive procedure? And if there's trainees involved, what are they going to do? Would you like to know what it's going to cost you? Do you want to know, when it's all over and it's been done right, what's recovery going to look like? Is it going to take me months to recover? Or am I going to be good to go in a few weeks or a few days? All these questions are important. And if you want to look at my study, it's just Google James Eakins Scully, Sculley, BMJ Open 2019. I tell you the title, but it's about this long. Thanks to the reviewers that wanted me to almost turn the title into an abstract. Anyway, give it a look. There's a table in there that says what reasonable patients want to know. And unless you're an unreasonable patient, take a little card in with your questions and expect coherent answers. So anyway, that's informed consent. And that's where my target is now, is to empower patients to know what informed consent is and go get it, even if they live in a state where the standard is the reasonable physician standard.
Thank you for that. We will definitely share that with our audience so that way they can print that and have that ready to go. I'm assuming they could kind of use it as like a checklist to kind of go through questions with their physicians, correct?
Yes, I would recommend looking at the abstract. The reviewers forced me to do statistics, which I didn't want to do, but I did it. And the statistical analysis, I think we stuck that in a supplement. It ran to like 70 pages or something. But my good friend from NASA, Bob Scully, whose name's on the paper, he did all that. The guy can figure out stuff that is amazing.
That's wonderful. And I'm wondering if I could maybe extract the questions and just put it on a separate checklist for our audience. Would that be okay?
Sure, sure. In fact, I might say a couple lawyers got a hold of it, and they used it to write an article for a law journal called Trial. And the title of the article I love is called The Power of Informed Consent. And basically, they wrote out how lawyers can use failures of informed consent to reinforce cases where malpractice may have happened. And that's an important step. I mean, I don't want to offend a lot of doctors by acting like we're trying to get into their knickers about what they're doing, but they know who's making the mistakes, but they don't tell. I mean, there's something from Marty McCary's book, Unaccountable. I think he wrote that about 5 or 10 years ago. I forget. I got it up here somewhere on my shelf. But he talks about a time when there were like 4,000 or 5,000 doctors gathered in some meeting, and somebody posed the question, how many of you know a doctor that's a danger to your patients? They all put up their hand. They know who they would never send their family to, but you don't know, and I don't know. And I wish I did know. The nurses also know. And there's a way to fix that, but it probably is not going to happen very clearly.
It almost reminds me of what we're seeing like in law enforcement, that there are some bad apples that people know about that have been cited over and over. And you know, the George Floyd case, that officer was a bad apple that had repeated offenses of harming people, and look what happened. So it seems to be, what's the term I'm looking for? It seems to happen in a lot of different fields, I guess you can say. But what I wanted to ask you, and thank you for that information for our listeners, when patients provide feedback for the service that they receive from their medical care providers, whether it's positive or negative, what happens with that feedback?
Oh, that is a big question. I think it depends. And it depends on who asks for the feedback. So right now I'm in a big system in Houston. I'm not going to name it. I kind of like it because when I'm asked to rate my doctor or the services I've received, it's by an independent group hired by Methodist, but not managed by Methodist, so that they get a really independent evaluation of my opinion of the care I received. So that's pretty cool. But if it's the hospital, let's say, sending you something about how good your care was, in the few cases I've seen that, they tend to be shallow questions. There's not going to be a question on there that says, given what you know now, do you think mistakes were made in your care? And if so, what are those? You know, they're going to ask questions like, were you comfortable? How was the food? Did they help you when you needed to get up and pee? Things like that. And that's okay. But they don't really want to know the patient's opinion of medical errors. And honestly, patients they know of some medical errors, but they certainly don't know all of them. I mean, if it weren't for my education, I probably would have never dug into my son's care. And I'll be honest with you, there are times when I wish I never had, because I kept finding things, and it at times was overwhelming to just realize how broken things were. But empowered patients, they can make a difference.
Thank
You know,
you.
let me go right back to informed consent.
Sure, absolutely.
So I said informed consent is seldom given. How do I know that? There was a study published in 2020, and the lead author was Erica Spatz, a cardiologist at Yale University School of Medicine. She had a 20-point scale for rating informed consent documents in 25 hospitals. So the best you could do was 20 points. The average of the hospitals she surveyed, and I think she did about a couple of hundred records for 25 hospitals, for a total of about 2,500 records. The average score was 4.5. So if you were a teacher and you had students scoring 4.5 out of 20, what grade would you give them? You'd probably throw them out. You wouldn't even give them a failing grade. I mean, it's really abused, and the evidence is there that it is. It's just we've got to find the right legislators to insist on shared decision making. Which, by the way, I just came across an article originally written in German, now translated into English, that says Germany in the last few years has passed a law that says clinicians in their country will do shared decision making with every patient that's facing an invasive procedure. It's law. It's also law in the United Kingdom. In the land of the home, land of the free and the home of the brave, it is it's up to the clinician to do this, and in a lot of good systems, it is being done. But I'm afraid to do it across the U.S. might interfere with the business model of healthcare in the U.S. But maybe down the road we can get it. Other developed countries are getting it. And I suppose your readers or your listeners know we pay more per capita for healthcare in this country than any other country, and our life expectancy is below virtually all other developed countries. There is something wrong here, folks. You got to get a crowbar out and pry it out if you can.
Wow, thank you for that. Yeah, I definitely, I know that from my own education that, you know, we rank, we were number 34, you know, on the quality of care. I don't know where we're at on that continuum of care quality in the world. Probably even more below, from what I'm seeing. But what I wanted to ask you is that, so protection is fairly limited, is what you're saying. There's no guarantee the medical boards will help you. What can a patient do if they have been harmed?
Well, in a state where tort reform is not the law of the land, they have probably a reasonable chance of getting some justice through the tort system. Um, you know, it's got to be a pretty clean-cut case. And my son's was not. As I said, there were a lot of people involved, doctors, and exactly who was at fault uh, was subject to further investigation. But somebody screwed up. You know, if you don't get justice there, you can go to the medical board. But I think what I would do on hindsight, if I had it to do over again, I would have tried to engage the public media in the fact that I was going to the medical board with my son's case. Lay it out, put it up on Facebook, put it up on other things, even LinkedIn, some things that are, you know, really substantive systems, and say, now I'm going to take this case to the Texas Medical Board, and here is the points I'm going to make to them. And I will let you know their response so that you make it a public spectacle to the extent that you are able. And people a lot smarter than me know how to do that in spades. And you might even engage somebody that's an expert in that. How do I spread the word that this is what I'm doing? Make sure the medical board knows you're doing that. Then take your case to the medical board and see what they do. And, you know, public shaming is not the best way to do things, but it works. So if you got the guts, do it.
We really love that answer, actually,
Okay,
for
good.
various number of reasons. That's kind of an inside joke with us. But, you know, what I'm really curious to know is that in your son's case, you said there were so many players involved that it was hard to like pinpoint a person. Do you think that these physicians, to reduce accountability and the likability of justice being served, they do this on purpose by adding on a ton of specialists to a case where they see a bad outcome in order to, again, to kind of save their ass in a way?
You know, that would cause me to speculate. I don't know what's in the heart of these doctors. In his case, I'll just say this a little bit more. I wasn't necessarily going to say this, but I will. So he saw a lead cardiologist at a hospital in Waco where he was going to school. But this guy, I found out later, had been studying theology in the few years before. Now, he was an experienced cardiologist, but I fear he wasn't up on his knowledge. But he did have the smart thing to do with my son, who had collapsed while running, was to refer him to what's called an electrophysiologist. You see, there are plumbers that worry about how clogged up your arteries are, and there are electricians who worry about how the electrical firing goes. And they're kind of two different communities. So electrophysiologist was called in from Austin, and my son was subjected to an electrophysiology test. And he had had a cardiac cath, by the way, which was totally unnecessary. And the plumber cardiologist in Waco had used fear mongering to get his informed consent for that. I won't go into the details, but he scared the hell out of my son. And so my son agreed to a cardiac cath, which didn't show anything and caused some copious bleeding at the place where they go in with a catheter. So he had the electrophysiology test, and that didn't show anything, but that was by a physician from a group in Austin. So now you got that involved. You had another cardiologist involved in evaluating his exercise stress test, for example. Then, when it was all over after 5 days, he was to have a follow-up visit with a doctor. And I assumed this would be a cardiologist. No. It was with a family physician in training who got her medical degree from a third world country and had somehow managed to pass the exams in Texas. Based on what she wrote in the medical record, she didn't know an echocardiogram from an electrophysiology test. That was her level of knowledge of cardiology. And she told him 5 days after he was discharged, there's nothing more we can do for you. And I remember that night, my son called and said, they gave me a clean bill of health, which is what he took that to be. And he went back to running. And it was only about a week or two later that he collapsed and died. And I might say this, he did some running with friends who ran a lot slower than him, and it didn't challenge his heart. But the first time he went out running by himself, I know what he did. I know my son. He ran as fast as he could, and that was the cause of his death. That and not having enough potassium in his body to keep his heart beating. And I remember, so actually they got his heart restarted after he collapsed, but he was in a deep coma. The night he died, I remember one of the cardiologists from Austin came and he told me, we were betrayed by our tests. Really? Really? Now, of course, at that time I was numb. I was facing the need to tell everybody gathered that my son had just died, and I knew, my family, my daughter was just starting at A&M, and she and her brother were very close. Anyway, I think that goes to the ability of doctors to rationalize what has happened. Tests don't betray anybody. Ignorance of the limitations of tests may cause you, the physician, to betray your patients. So, and that sticks in my head. I can't believe that. Anyway, the doctors do keep their secrets, and they are a closed community. And I'm working with some people. They want either a national patient safety board, like the National Transportation Safety Board, to look into events like what happened to my son, independent of the Texas Medical Board and the people in the hospital, and say, look, this is what you should have done. There's also a move afoot that just went by yesterday or the day before that we would like a division to deal specifically with medical errors somewhere in the federal system. It would do science and deal with apparent medical errors in a scientific and thorough way, independent of the medical care system. And it would have power to subpoena records. Patients would get interviewed in a timely way. It's just, there's a lot of things that could be done. Just like when there's a plane crash, the National Transportation Safety Board is all over it. Why did this plane crash? But one of the problems, as everybody points out, is we got a lot of plane crashes here in medicine. And boy, it's not going to be easy to tease all this out. It's an interesting area to deal with. I've been retired 7 years, and I stay busy doing this. In fact, my wife complains. She says, you're supposed to be retired and you're not acting like it. And I don't intend to act like it. You burn out sometimes. I'll tell you, you fight a battle and you lose. And you go back away with your tail between your legs and you're thinking, is this really worth it? But then you talk to some of your colleagues and they pump you back up again. and we go at it again. It's the patient safety movement.
This is exactly what Keely and Eric and I do. And Eric, below, I'm going to turn the questioning over to you, but he's been fighting the medical system, scientific research for the last 35 years into the investigation of chronic fatigue syndrome at ground zero in Lake Tahoe when the mystery malady took place in the 80s. And he discovered that, you know, teachers were getting sick in buildings where there was a specific type of mold, Stachybotrys mold, found. And the CDC, the NIH, these people came in, and that evidence was just discarded and kind of covered over with all these different definitions, renaming of things, having all these different types of research that is extremely inconclusive. You know, they tried to tie it to viruses, they couldn't. So Eric is very, very, very familiar with that, and I'll allow him to chat more about that.
Yeah, it was 35 years ago that I became aware that doctors have kind of a hit and run mentality where, you know, there's a crash, their car shutters, and they kind of go, did I just hit something? But they don't stop. You know, any reasonable person would go, wow, you know, my car made this horrible noise. I've got blood all over the windshield. I really ought to stop. And doctors just keep proceeding on and act like nothing has happened. And later when you say, why didn't you stop? You know, this is beyond the point of wondering that something bad has happened. You know, isn't there some kind of switch from, you know, going to maybe something happened to I know something happened, and just check out the situation. And as soon as they launch into this excuse, well, maybe I didn't know. Maybe it was an error. Maybe I just didn't have training in that field. Their brethren, their colleagues, close ranks around them, support this loss of the kind of integrity where somebody should reconsider the situation. And that's why I got involved in this chronic fatigue syndrome, because I was concerned at this behavior of doctors and wanted to do something about it. And I think that we really do need some kind of review to test doctors for whether or not they're going to revisit a situation. Maybe send like a shopper in, like the hired people that go in to check out grocery stores. You just send somebody with an unexplained medical complaint into a doctor, not to see if the doctor is capable of making a diagnosis in an unusual disease, but at least whether they make a sincere effort. And if something abnormal shows up, are they going to follow up on it? That's all we're asking.
Yeah, I think that, as to the extent that I understand what you're describing, Eric, that is a challenge for physicians. You're really talking about an environmental problem. And as I'm sure you know, there's plenty of companies out there that will come and take samples in your house or your workplace or whatever and see what they find. One of the things we always did in spacecraft, by the way, because you've got humans crammed in there and there's no fresh air. You're using the same air over and over again. The microbiologists did a lot of sampling and looking for fungi and bacteria and so on. But as you allude, the symptoms are kind of non-specific, kind of like you have a bad day, day after day after day. And it's a tough problem, but it's important.
I'm really dealing with two separate issues here. Yeah, there's the science of it, and then there's the sociology. Now, when it comes to the toxic mold incident, I can appreciate that they didn't know what was going on, so we could classify that as an error. I mean, that's okay. People make mistakes. This can be forgiven. But what happened was a brand new test came out, that an EBV serology test that showed fluctuating levels of Epstein-Barr virus. Now, this is a virus that nearly everybody has. A normal, healthy immune system is easily capable of controlling it. In fact, if you cannot control this common kissing disease, the Epstein-Barr virus, this should be a signal that something is seriously wrong. And it used to be seen that way. This is a sentinel of some kind of immune dysfunction. Well, a new test had just come out, and it was applied to people in these sick buildings, and it showed that they had a faltering immune system. They were no longer capable of keeping this common EBV in restraint. So this is a red flag. It's a clear, unequivocal marker of something going wrong. But doctors decided that it was inconvenient to look into this. They didn't want to deal with what was going on in the buildings. They didn't want to recognize that they have a responsibility to follow up and get to the bottom of this mystery. And they started saying that this test is inconclusive. It's not widely accepted, at least at the time it wasn't, because it was brand new. And they portrayed it as error when it was obviously a case of negligence, because anybody with medical training would know that the test was reliable. These fluctuating EBV markers did indicate something was wrong, and at the very least, there needed to be some follow-up. So my issue on this is really the lack of integrity in doctors, where they recognized, they knew, they understand, they were all medically educated, they were aware that something was wrong, and yet they deliberately cast this entire episode as some kind of error to escape responsibility for it.
Was any of this taken to the FDA? Because that's where such a test would be approved for marketing, let's put it that way.
Yeah, this was the actual center of a Center for Disease Control investigation. So this is the most controversial incident in medical history. If you just look up chronic fatigue syndrome in Incline Village, this is the puzzle that has set the entire world into confusion over what chronic fatigue syndrome is. You have people theorizing all over the world, putting forth their various hypotheses, yet the issue, in my opinion, is why don't they come back to where the mystery started, look at what happened, evaluate this test, and determine, was it an error or was it negligence? And this is what they refuse to do.
Okay, then what about in other countries? Has this been presented and approved in other countries or evaluated?
Yeah, this problem, this controversy started out very small with just 160 of us in a very small town. And now the controversy has spread throughout the entire world. Different countries use the original chronic fatigue syndrome definition as a model. So their definitions are derived from the original, but essentially by making a comparison and using our original definition as their model, they are connected as a research instrument to try to get to the bottom of this mystery. And in every case, in every country, even though they make up even a different name, but say this is intended to solve chronic fatigue syndrome, they ignore the way this fluctuating Epstein-Barr virus antibody test shows that there's a faltering immune system, and this puts a scientific obligation on researchers to try to get to the bottom of this mystery. And they are still, to this very day, presenting this as some kind of mistake, possible incompetence, error, they don't know what to look at, when it's a very simple matter. Why is the immune system failing, and why is it failing in sick buildings?
So I think, if I understand what you're saying, in each individual, there's a fluctuation, if you will, in the immune competence.
Exactly.
It goes up and down. And in some individuals, it's a much lower average level, so that these people are more susceptible to EBV and chronic fatigue.
Yes, the Epstein-Barr virus was simply the first thing to show up when the immune system started to fail. But they quickly noticed that other viruses, cytomegalovirus or parvovirus or human herpes virus 6, any number of viruses this loss of viral restraint was occurring in them as well, and even in bacterial and fungal infections. But rather than try to put the pieces together, they keep insisting that, well, you've got a viral infection, but we don't know why. And they refuse to examine the circumstances, both under which people are getting sick and how this antibody serology test is an indicator of something wrong that requires, it places a demand on a medical professional to try to get to the bottom of this mystery. And they are pretending that they cannot understand that here is something that needs to be solved. So the question for me is, do they really fail to understand in their mind? Do they perceive this as an error? Or is this like a hit and run? They know they hit something. They know they're supposed to stop and look into it, but they're going to pretend they didn't because they don't want the responsibility.
I hate to sound cynical, but you can get people to look at things if there's money in it in medicine. That's pretty cynical. There's a lot of good doctors and researchers that do it because it's so passionate. But in the end, if you could get, and maybe you've done this, I'm sorry, I don't know, but get a major company that does tests like this and markets them to get behind you, and maybe do some further research, shore up some loose ends if those have been identified, and then go at the system again. But get a big company that thinks they can make some money with this and get them behind you, because it's about money.
Well, you're right. And you want to say there are good doctors. Well, this is like a test. Creating a syndrome is like putting out a test, a challenge to all doctors. Okay, doctors, here's your chance. Prove yourself. Are you a good doctor? You see a conflict here. You see a situation that needs to be reconciled. Are you going to step up and do it? And so far, they decline to do so. Now, you would like to think that people aren't into it purely for the money, but if you examine those who have become interested in this problem, it is only those who have made themselves high-priced specialists, and rather than work together to solve the overarching mystery of the chronic fatigue syndrome, they only tell their patients, and they've all tripled their prices. So I don't consider that the hallmark of a good doctor. To me, that's pure greed. A good doctor would act with integrity because they would want to solve the overall picture for everybody.
Yeah, but the thing, it's not really incumbent on individual doctors to deal with things like this, I think. It's up to the specialists who are demonstrably knowledgeable in this area to say, by God, this is an important test that needs to be done. I'll put my reputation behind it. And somebody with the funding needs to make sure this gets approved by the FDA and go from there. And it seems to me
this test did become the gold standard, absolutely, and it's reliable. In fact, the CDC was using it to prove the existence of the chronic active Epstein-Barr virus syndrome. So it was fully accepted at the time doctors went into denial. So to me, they know that the test is reliable. And if they try to pass the buck by saying, well, I'm just an individual doctor, I don't think that shows sufficient integrity to actually be in the profession. Because doctors are supposed to be disease detectives, skilled diagnosticians. If they can't see a problem with this, they've kind of gone over the line, because now they've got a definitive test that is telling them, here's something that needs to be looked into. And to say, well, I'm not trained in that area, or because I don't have an answer, I don't even have to look. That's the hit and run mentality that I'm talking about.
Okay, so here's the other way to go about this. Yeah, I'm sure you're familiar with medical guidelines, given you've got some kind of problem, medical problem. There's guidelines on how to treat it, or in many cases, how to prevent it or detect it in an early stage if it's cancer or something like that. All sorts of guidelines. You can get the people at the CDC to work with something like maybe the United States Preventive Services Task Force, It's the gold standard outfit for setting guidelines for certain things, and say, okay, to the CDC guys, I think it's time you started working with this preventive task force that makes guidelines to get guidelines for diagnosis of chronic fatigue syndrome. And we will support you doing that. Now, I don't know if you can get CDC to move. I've tried to get CDC to do several things that I thought were very smart. And they just don't do it. It drives me nuts. But apparently they made a ruling in the case of this EBV test. Is that right?
Yeah, we can't appeal to the CDC because they are the architects of this confusion. They are fully aware of this. They are the people who are behind this deception.
Oh, I didn't understand it that way. Well, I think,
as you said, our mission here is trying to take this to the public, explain the situation, that here is something that is kind of crossing the line. It's going from medical error into a case of actual negligence, demonstrable negligence, where they're ignoring this red flag for maybe because it's inconvenient, maybe for money, maybe who knows their agenda. But the fact of the matter is, if you hit something with your car and your whole car shakes and you've got blood all over the windshield, you need to stop and check it out.
No, I see your analogy there. And I don't think that this is being singled out. One thing I found when I wrote my book, A Sea of Broken Hearts, and this is from the National Library of Medicine. They asked a question in about 2000, how long it takes frontline clinicians to start using an obviously valuable and capable test. Something very simple, obviously an advance. And this 50% of the clinicians that should use this will be doing it in 15 years. No kidding. 15 years. Yeah. And if you want to look at my book, it's referenced in there. National Library of Medicine. I think they did 6 different, very straightforward, obvious measurements. And in those days, it took a long time to get to the front lines. Now, if it's going to make money, it'll get there a lot quicker, I'm sure, these days. And of course, communication is much more furious now than it was in 2000. But I was surprised. Maybe it was 17 years, 15 years, but that's only half of them.
Well, we saw that exact model with the H. pylori by Professor Barry Marshall.
Yeah.
After H. pylori was testable and demonstrable as a cause for ulcers, we watched to see how long it would take for this information to permeate the medical profession. And as you say, 15 years later, only half of doctors were actually using this test. The rest of them were still going with the stress causes ulcers theory.
Well, see, this goes to my point I made earlier. Medical errors of omission. That is when something should have been done. There's a consensus it should have been done, and they didn't do it.
And they read about it, and you have to ask yourself, when did it cease to be an error, and when did it turn into negligence for profit? Because they felt there was more advantage to them to continue on selling their books, their bland diets, their ulcer medications, than to actually cure it using these antibiotics. Yep. So really, it's a matter of demonstrating that they have been made aware, and they do understand that here is something that they need to respond to, and to pass the buck should be a disqualification to even be a medical practitioner.
Okay, Eric, then this is a question I often get, and it's, so where are your allies and where are the barriers to getting where you want to be? Do you have allies? And
I have unwitting allies. Everybody who's been injured by a sick building is my unwitting ally. They just don't know it yet.
let's say active allies then. Somebody with good punch.
He's just stuck
Got
with
these-
us. He's
Just
only got us.
That's right.
We're not very hard hitters.
Well, you got to be, but you got to, you know, I'm thinking, I know of somebody who used to work at NASA, and I think on his team was a world-class virologist. And I could get him to look at your stuff. I could connect you guys and see what he thinks. I mean, you might get an ally there.
Yeah, well, if you were examining the interior environment of a spacecraft and saw an unidentified microbe, maybe a fungi, growing all over the wiring, and it wasn't in the literature, it didn't appear on it, could you simply ignore it? Say, well, we've tested it with our known tests, and we don't really understand what this is, so it doesn't exist. We'll just ignore it. Is that an error or is that negligence?
Yeah, no, actually, it's a very good, interesting case, because we built a space station with Russian modules and US modules, and the Russians used some kind of fabric or something on the wall of their vehicles. And we noticed with the videos that there was something growing on that thing. And believe me, we got on that quickly, because you don't want a fungal infection going around in a closed space. Now, there's a lot of good filters, but still, you're going to have dead spaces and things like that. And you get an infection started with 6 or 8 or 10 people stuck in these cans, and you could have a real problem, because it's going to spread quickly. And they are stressed, by the way. There are immune changes that happen to astronauts when they go in space. And that's well chronicled. Now, whether those changes make them more vulnerable or not is, at least when I left 8 years ago, 7 or 8 years ago, that was an unresolved issue. But there are immune system changes. So we were especially careful about bad microbes. And
Yeah,
anything growing on the wall is not good.
Yeah, and I've read about the fungal problems, the microbes they have growing in the space station. And so it's amazing how we've got a double standard here, where if we see that same situation in our astronauts, in something that people really care about, it will get studied and they'll work on it and they'll solve the problem. But if it happens in a room full of teachers, it gets ignored.
That is a very deep sociological problem. You know, who cares about teachers? And there's 2 lovely women on this call. But professions that have traditionally involved women doing the work have been exploited, I think. And that's teachers and nurses. I think it's been exploited. And the problems that arise there have been discounted by a system that doesn't care as much. I think you guys probably know that our abysmal record with maternal and newborn care in this country. We're right down there with Cuba and other countries we consider third world. What are we doing here? And my daughter has given birth to 3 kids, and I will guarantee you the third one she had by a midwife, because she had the first 2 in hospitals, and she said, I'm not going through that SHIT again. She didn't say it that way. She's a nice girl. But, she was very unhappy with the way they treated her in the hospital. She was basically just, just a problem. Here it was Saturday night, she's giving birth. How can you be giving birth on a Saturday night? I got plans. And the other one was, let's stage this with Pitocin so that I can come over in my lunch hour and help you birth your baby. Really? How about we just let the baby come out when it's supposed to? You want a episiotomy? No. Well, I gave you one anyway.
Yeah,
Midwife was good.
that happened to me. I had an exposure, and I was in Las Vegas, and I went to the ER probably a few days ago, and that's how I was treated by my intake nurse. He looked at me like I was impeding on his time. You know, I walked in that ER completely empty, literally no one around. And he was sitting around doing nothing. And I came in and he was like, oh, you know, really minimizing my situation. And I'm like, what is going on here? You know, like these people are at work. This is what you're supposed to be doing. Why are you making people feel like they shouldn't be coming to the ER when they have a problem? You know what I mean? It's ridiculous.
So, but anyway, Eric, we've really strayed from your points. I will connect you, if I can, with a Dr. Satish, a neat guy, smart as hell, and you guys can figure out what you want to figure out on your own. But what you're really, okay, and you guys can go from there. If it leads over to toxic fungi and something else, he can probably tell you who is world class in that area. So, I mean, that's all I can do, because I don't know.
Yeah, actually, the toxic mold phenomenon has been extensively studied since this incident, and it is extremely well understood now. There's no doubt about it. In fact, by 1994, there was no longer any question of the toxic qualities of Stachybotrys, the actual fungus that we found. There was no question that this was fully capable of suppressing immune responses and allowing EBV to get out of control. So the matter was actually settled. But what doctors are doing now is saying, well, we've moved on since then, so we don't need to address that, explain it, solve that syndrome, or ever make any self-correction in the literature. In other words, they've made a mistake, and it moved from being an honest mistake into a cover-up.
Yeah, that doesn't surprise me, I'm sorry to say. I mean, I might say, I didn't mention this. In my son's medical records, there were critical falsifications, blatant lies.
And once you can demonstrate that these deliberate falsifications were perpetrated, it's no longer an error. We're talking negligence.
No, that's culpable negligence. When you intentionally do a cover-up. In my son's case, he was offered a loop monitor. I was there when the offer was made. When his medical records came back, suddenly he was offered a pacemaker. He was never offered a pacemaker. He did refuse the loop monitor, but through all his records, and you can see in his records, by the way, from the electrophysiology test, that he was offered a loop monitor. But the main medical records were back at the first hospital he was at. That's for 4 days, and then one at the second one. And those were filled with the idea that he was offered a pacemaker and refused it. That's a total lie. Didn't matter. Total lie. I don't even know if the medical board figured that out. You didn't have to be real bright to figure it out. But then again, my opinion's not unbiased.
And then we have the innocent bystander strategy, where all the great white wall of medical professionals who saw the situation and are easily capable of understanding how these falsifications were made, strangely don't say a word.
Yep. What's the monkey thing? Hear no evil, see no evil, speak no evil, even if I'm sitting on top of evil. Or negligence. I mean, in Texas, the Christopher Dunch case is a good example. It was well known the guy was abusing patients for years, but to get rid of him, you had to give him a half-decent reference. So you give him a half-decent reference, he goes someplace else. He's in jail right now and will be until Keeley is an old lady. How's that? Count years.
I had a question about like what happens when these doctors are actually pinned on their bad behavior? Like, do they just bounce around from hospital to hospital just so people can get rid of them? Or like what happens in that process?
They do sometimes bounce around. Sometimes they get out of the medical profession. I didn't mention a book I co-edited called The Truth About Big Medicine has a chapter in it written by a physician that faults the peer review system that doctors are supposed to use to call out bad actors. It is a seriously flawed system, and he documents this. He's some cardiologist in California killed like a whole bunch of people, scores of people, with his bogus cardiology. But here's the answer to your question. He was flying under the radar. He would kind of had his own little business over here. And that's the way the guy in Michigan, Farad, I think was his name. He was deliberately misdiagnosing patients as having cancer and then putting chemotherapy in them. And nobody was picking this up because he was kind of doing this under the radar. And he got away with it for a lot of years until somebody figured out he was poisoning people just for the money. And he's also in jail.
So basically what you're saying to just us, our audience, is that you just can't blindly believe and trust people in white coats. Is that correct?
That is correct. That's why things like informed consent are so important. And that's why you've got to ask questions. Looking back on my son's care, there are some regrets I had, and this is maybe important. My intuition was that his first cardiologist wasn't on top of things. Intuition's funny because you can't logically explain why you feel that way, but you feel that way. And I did, and I should have listened. I should have brought him back to Houston where we could have gotten some competent cardiology treatment. But in a modest town like Waco, you don't get the world-class cardiologist. That my son needed an enlightened cardiologist to treat him, and I just didn't know that. So, and these doctors are all nice. They're nice people. You know, be careful who you trust. Some of the nicest doctors may be the ones least technically capable. They're just nice people. So be careful how you weigh things. But Eric, if I assume I can get your email from somebody after this is over, and I will try to connect you with Dr. Satish, and you guys can roll the ball from there. I don't want to be part of the process, but in fact, one of the things I enjoy now these days is putting the right people together and then getting out of it and let them figure out what they want to do or not.
You mentioned peer review, the system as being part of the problem, because they can actually filter the information that they want doctors to see and remove things that are troublesome to them. And this episode that I talk about, the chronic fatigue syndrome, it was based on a specific outbreak at Lake Tahoe where this serology test was applied. And having once decided to cover this up by portraying it as an error, they, the CDC managed to delay for about 4 years and said, well, we're going to redefine chronic fatigue syndrome. They created a new definition, the 1994 PACUDA definition, which was supposedly in the name of progress, when in reality, it shifted the playing field so that this act of ignoring the EBV serology test was removed. And now people consider chronic fatigue syndrome to be nothing more than what is in that PACUDA definition. So it was a way to cover themselves.
Well, that doesn't surprise me either, Eric. It doesn't. As I said, I've been frustrated with CDC. And for example, here's one. So my daughter, who's otherwise a very smart lady, is an anti-vaxxer. And one of her problems is she doesn't think all vaccines are the same. There's good ones and bad ones. So I asked the CDC to take their damn data they have in their database and rank vaccines. The ones that have very low risk and are very effective get an A and on down to D or F, so that people that want to selectively pick vaccines can do so. Deaf ears. They don't care. They don't care. But I think that would be a valuable tool. And even with the coronavirus, the COVID-19, you know, I don't know what rating the vaccines would get, but, you know, tell people.
Well, with your situation, were any measures taken, any changes that were done to make sure that what happened to your son never happens again?
I cannot say that for sure. What I can say, my book got quite a bit of attention. There was a cardiologist at Rush Medical School in Chicago who wrote me and said, "Thank you for writing your book. The first thing I think about when a patient has arrhythmias, heart arrhythmias like your son did, is potassium and magnesium depletion." The first thing she thinks about. And I don't know how she found out about it, but I think it kind of went through the medical system. I can tell you by 2017, when my 92 or 3-year-old dad was in the hospital, they got right on his potassium deletion problem. And he didn't have serious heart arrhythmias. He had some. And his potassium level was just about where my son's was. But they got on that like bandits. So I'd like to think the answer to your question is yes. I hope it's yes. But I can't prove it. But there's been some good vibes out there.
Thank you so much, Dr. James. We didn't want to take more of your time. I know we went a little bit over the hour. Was there anything else that you wanted to cover or discuss or anything else like that with our audience?
No, I might tell your audience the way I sign my emails.
Sure.
I sign it, be well or be careful. If you get sick, you better be careful. But try not to. Be smart. So that's all I would say. And thank you. Thank you for giving me a chance to vent and say some things. And I will look for Eric's email and I'll connect you with Dr. Satish. And what happens from there is going to be transparent to me. How's that?
Thank you.
Perfect.
Thank you, guys. Have a great.
We're so grateful for you. We hope we can actually do this again with you, maybe on another topic, or maybe talk more about your DASA experience, or it doesn't even have to be recorded. I mean, you're just such a cool individual and very open-minded, and you know, just I feel for you in your situation, and I'm so sorry that you had to go through what you went through. But as a result, you are helping a lot of people get through this kind of stuck mindset where people think that whatever the doctor orders is what exactly they need, and understanding that doctors are fallible just as anyone else, and they're not always competent. And that is an extremely poignant point to write upon, because you know, my family they're one of those proponents where whatever my doctor says is what's best for me, you know, and it's like, well, let's look at the drug side effects. Let's look into this further and make sure this is actually what you really need, or these are the procedures that you really need. So I'm kind of like that patient advocate for my family, and I'm sure Eric is for his and Keely is for hers, because we've been there with our medical care providers where they have failed us with our mold illnesses. So,
that's very well put. Yes.
Yeah. Thank you again, everyone, for listening. Please like, share, subscribe to our content. I will go ahead and link Dr. James's book below, Sea of Broken Hearts, as well as his newsletter and all of the other resources that you can use to make sure that you are receiving safe medical care and that you are being your most important advocate during your care during that time. Again, please check out our Patreon and GoFundMe pages to keep this podcast going. We're so grateful for all of you, and we'll see you next time.